Good evening, everybody. I'm Dr. Robert Lowe, and welcome to Updated Protocols for Provisional and Definitive Cementation in Indirect Dental Restorations. I'm doing this webinar tonight from Charlotte, North Carolina. At the top of the program, I always go through the list of all the people from around the world. Welcome, all the different time zones. It's 7 p.m. on the East Coast of the U.S., and I know there are a lot of people throughout the world that are up in the middle of the night or early in the day and are going to join us for this hour presentation, and I thank you for taking the time to spend with us. I also saw that my good friend Daniel Gomez, Dr. Daniel Gomez from San Pedro Sula, Honduras. Daniel, ¿cómo está? Haven't seen you or talked to you in a long time. Hope all is well. And I'd like to thank GC America for sponsoring this webinar this evening. I'm going to begin the presentation tonight discussing provisional cementation, because often, we forget that very critical step of provisional cementation during our crown and bridge process. Just to give a little basic background history on provisional cements. Initially, the first provisional cements were zinc oxide powder and eugenol liquid, or ZOE as termed, developed in the 1890s. And we've used ZOE, or zinc oxide eugenol type temporary cements, in our profession for many, many years. Obviously, in the early days before high-speed rotary instrumentation, we get a little bit of irritation to the pulp during the preparation process. ZOE was a nice soothing medicament and obtundant for pulpal discomfort to help settle the teeth down a bit while the patient was in temporaries waiting for their definitive restorations to be fabricated. And ZOE is still today a very popular temporary cement, although from personal experience in 30 years, I remember using many of these types of products throughout my career. And a couple of the points that we'll bring out in the provisional cement portion as to being clinically important to me, one of them being cleanup. ZOE temporary materials are very, very difficult to clean up from plastic, bisacrylic, methyl methacrylate type provisional restorations. The zinc oxide smears all over the place, and oftentimes it takes many minutes of laboring to get all of the ZOE temporary material away from the provisional marges before we would dismiss the patient. As composite resins became more popular in the 1980s, suddenly there was a need for a eugenol-free temporary cement, because eugenol interfered with the bonding of composite to tooth, and many times now amalgam was being replaced by some type of bonded core material for crown preparation prior to the delivery of the definitive restorations, or we would be cementing a definitive restoration with a resin material, and eugenol, if it remained on the tooth, would not allow that resin to set properly. So more and more now, ZOE temporary materials themselves are not used in this day, except for traditional PFMs. As we go to metal-free and bonded type of materials, we needed to have a material that wouldn't interfere with the bonding process. Going on in the process, resin temporary cements were also developed to address the need for provisional cementation of veneer restorations, because the typical provisional cements at the time would not have enough retentive capability for these minimal preparation type of cosmetic restorations that have been popular since the mid-90s. So resin temporary cements are developed. We still don't see too many of them on the market, but one thing, resin enhancement of ZOE or eugenol-free zinc oxide type materials have helped in the cleanup of these cements tremendously. But as mentioned here in the text, these types of cements, resin temporary cements, can make it difficult to remove the temporary. You know, that's the quandary we all have with provisionals. You want them to stay on until they're ready to come off. You don't want them to come off too early. You don't want them to be too difficult to get off. And the other thing that I still find with a lot of clinicians who are in the habit of not anesthetizing patients at crown delivery, they want to have a temporary cement that sticks to the temporary, not to the tooth, and that really ends up, in my mind, being counterproductive, because if the temporary material sticks, if the cement sticks to the temporary, that means the temporary itself, unless there's good retention in the preparation, is very non-retentive. And you know, temporaries only come off at a very inopportune, inconvenient time for the doctor. Hence, provisional cements. As noted, source here, Dr. Howard Strassler from Maryland. So I want to introduce you to a relatively new provisional cement on the market by GC called Fujitemp LT. Is, to my knowledge, one of the first, or may still be the only, glass ionomer provisional luting cement on the market. And we think about the positive products of glass ionomers. We think about ion exchange, and we think about release of fluoride and those types of things, which are obviously good properties to have in any cement. But let's think about provisionals for a second. I mean, how well do provisionals really fit to the tooth? I mean, provisional margins are certainly nowhere near have nowhere near the accuracy of definitive restoration margins, which can be as little as 30 microns. I think we're all pretty happy clinically if we have a 300 micron provisional margin. So in a time when provisionals are often in patients' mouths longer than the obligatory 2-week turnaround time from the lab, whether it be to evaluate a potential pulpal issue, or to nurture the periodontium to healing from over-contoured previous restorations or periodontal surgeries or what have you. Patients may be in the provisional restoration for several months, and this means acid attack to the margins, particularly when provisional cements in general are extremely soluble and wash out rather rapidly. So, a provisional cement with glass ionomer and fluoride releasing capability seems to me to be something that is a highly desirable product to have. Some of the features and benefits of Fujitemp LT: excellent handling with low film thickness. A 6 micron film thickness is a negligible film thickness. When we went back to the days of curing luting, curing adhesives on dentin prior to placing resin cements, we got worried of increasing film thickness and altering the fit of our restorations. Then pretty much standard 10 micron film thickness would be negligible as far as affecting the fit. So you have a good fitted provisional restoration that will seat to the proper position with a 6 micron film thickness. That's very good. Is it easy to clean up excess cement? Because you know what? I've always said, if you leave temporary cement in the sulcus, you might as well have calculus there, because it's going to be an irritant. It's going to create chronic inflammation and bleeding, and when the patient comes back for a definitive delivery, if you're planning on using any type of resin cement, or whether total etch or self etch, extremely difficult to maneuver with these types of materials in an area that's bleeding or where moisture control is impossible. So nurturing the health of the tissue in the provisional phase of treatment is critical, and cleaning up the cement adequately is very important. In fact, on my delivery tray or delivery system, I have a piezo scaler with a thin perio tip that I use to remove both temporary and permanent or definitive cements after placement of restorations. So easy cleanup is, I think, a very positive thing. High bond strength, Fuji Temp LT, as I said, I want my provisionals to stay on until I'm ready to remove them. Typically, it will take a curved hemostat and breaking of the cement seal to remove the temporary, particularly if it's a multiple unit temporary. And sometimes the cement comes off mostly in the temporary, but there may be a little bit of cement left on the dentin, which I remove then with a piezo scaler. Excellent thermal insulation with this product. Again, provisional margins don't seal well, and you want to, I still tell patients there may be some temperature sensitivity while in provisionals, but having a temporary cement that has good insulation to help protect against sudden changes in temperature is a good property. But high fluoride release and recharge, to me, this actually should be all in capitals. This is a unique property of this temporary cement, I think, that is important for any provisional anytime. And then lastly, because there's no eugenol, obviously there's no effect on the final cement, which is common with a lot of temporary materials out there. So the material comes in a paste-paste system. Equal amounts of A and B, easy mixing, load the provisional. Now this graph is an interesting one to look at for just 1 second, because if I highlight my cursor here and show you the highest releasing amount of fluoride in Fuji Temp LT, higher than any of the other Fuji products. Here we've got Fuji 1, which is cement. We've got Fuji 9, which is a build-up material. We've got Fuji 7, Triage, which is a Pitt and Fisher material. There isn't as much fluoride release in these materials as there is in the temporary cement. So a lot of protection from fluoride release. Here I've got a case from a few years back where we were looking at doing some restorations for this patient for cosmetic, aesthetic, and functional reasons. Most of the time it's a combination of aesthetics and function. You can see this patient edge to edge. She may be in her 50s, but her teeth look like they're in their 80s chronologically. Because of edge-to-edge wear, she's worn down considerably the incisal edges of particularly the central incisors, but the lateral incisors as well. So part of the goals of treatment here is not only to create a better aesthetic look, but more importantly, in my mind, to recreate anterior guidance and canine disclusion. Although we're not going to be in the canine region here, we're at least going to get anterior coupling with the canines present and the anterior teeth during excursive movements. Now, as you look at the slide on the right here, I'm highlighting with the cursor. I take my fine tip Sharpie. I'm going to be doing some gingivectomy here because I want to increase the width to length ratio to make these teeth look more normal. You can only add so much to the incisal edge, and if there is free gingiva present here, I can use a diode laser and I can remove some of that free gingiva. For example, if that's a 3mm sulcus, I can take away 2 millimeters with a diode laser, leave 1 millimeter of patent sulcus, and do no bony crown lengthening. If we invade that last millimeter, however, bony crown lengthening is needed, and we do that in some cases, as we will show in this one, with an erbium laser. But here's the diode laser, first doing the corrective contouring to the gingival zenith. Here you can already see a much better situation here. My mentor, Harold Chevelle, always said the tissues over the central incisors should be slightly higher or apical to the tissue over the lateral incisors, and then the canines either at the same level of the centrals or slightly apical or above. So we've achieved that position with the gingival zeniths over the laterals and centrals. And we go on then to the next slide. This is a slide showing the provisional stent made from a preoperative wax up that was duplicated in stone. And then this Essex bleach tray material, actually Trayrite, was suck down on the model, thermoformed on the model, based on the wax up. I can use this also as a prep guide. I can see the outlines of my preparations within the confines of the wax up. This will then be filled with a provisional material. In this case, a bisacryl material, carved and polished, and then ready to be cemented. The Fuji Temp LT is extruded in equal amounts on a mixing pad, mixed with a cement spatula, and then using a plastic filling instrument applied to the inside of the provisionals and then pushed to place. Now, as this sets, this excess will plasticize almost to a rubbery type consistency. You may be familiar with Duralon. Duralon has this rubbery phase that when it reaches that phase, very easy to clean up, and Fuji Temp LT is exactly like that. We clean up with an Explorer or a Scaler at that rubbery phase, and we're ready to dismiss the patient. Now in this case, as I said, because we do go now in sound, and we invaded the last millimeter of sulcus a little bit, here you can see this is the 3 millimeter mark on my perio probe. If I sound to bone and I don't see that little black line denoting 3 millimeters at the free gingival margin, which is John Coyce's magic number, 3 millimeters from the free gingival margin to the crest of the bone for happy biologic width. Now we need to do some crown lengthening, but it's only going to be in this area where we raise the eyebrow, the gingival zenith. And for me, for over a decade, that's meant closed flap crown lengthening with an erbium laser. And I take the tip of my 600 micron tip and my erbium laser. I use it as a perio probe. I put a black mark at 3 millimeters, and when that black mark is at the free gingival margin, that laser is recontouring the bone 3 millimeters apical to that point. So this is a closed flap crown lengthening. If you'd like any information on this, please send me an email. If you didn't copy my email address, boblowe, B-O-B-L-O-W-E, DDS at AOL.com. I have several articles I've published, and in fact I'm opening a classroom. I'm a member of Catapult Speaking Bureau in the U.S., and I'm opening a Catapult classroom which has articles and videos and things like that. If you send me your contact information, I'd be happy to send you some information on how to link up to that when it's up and running. So closed flap crown lengthening, and the patient leaves. Now the temporary cement's cleaned out, the bony correction has been made. These restorations will be made within a period of a couple of weeks, 2 to 3 weeks, and then the definitive restorations will be delivered. So on that note, let's move on to definitive cementation. We have so many different materials today. Restorative materials, from porcelain fused to metal alternatives such as Captech. All ceramics. Our all ceramics started with materials like Procera and Inceram, aluminous porcelains, and then went to pressed ceramics. We've always had felspathics. Felspathics were what our first porcelain jackets were made of, the restorations that were beautiful before their time because all we had to cement them with was zinc phosphate cement, which is our definitive cement of choice if we go back to the 1960s, and all we're cementing is gold and porcelain fused to metal. Zinc oxide, that's the other side of the zinc oxide eugenol story. Zinc phosphate cement is soluble in oral fluids, has 0 bond strength, and doesn't have any fluoride exchange or any chemomechanical retentive properties whatsoever. It fills the void. Now today we have so many different types of materials. What I'd like to try to do in the remainder of our webinar is show you a couple of different cements and applications of those cements with some of the different materials that we're presently using today. So quote-unquote permanent cements, and this information I paraphrased or got from Dr. Mark Latta, who is the former Associate Dean for Research at Creighton, but now the current Dean of everything at Creighton. A good guy, and he's always my go-to guy for any questions in dental materials. And he lists the permanent cements as we go chronologically from the oldest, zinc phosphate. The next popular cement was polycarboxylate or Duralon. Then the glass ionomers became popular and the fluoride release. Now if we look at these first 2 cements, these are both soluble in oral. Well, actually, all three of these are soluble in the oral fluid. Zinc phosphate has no bond strength whatsoever. Polycarboxylate has some chelating properties, chelates to dentin. Glass ionomer, very weak bond to dentin, but there is some bond nevertheless. Then we move on in the category. Resin-reinforced glass ionomers. When the resin-reinforced glass ionomers became popular and started being used, these were some of the first cements that became insoluble in the oral fluids, and that was a big property for us. Low film thickness, insolubility. You know what? After 30 years, and being taught in dental school about closed margins, hate to break it to everybody, but there's no such thing as a closed margin. It just depends on how open the margin is, and what's in that gap is going to be luting agent or cement. So you want something that will not wash out, that will resist acid. Resin-reinforced ionomers became the cement of choice at this point in time in our history. We get some bonding to dentin. There's some limited fluoride release, although depending upon how much resin is in the resin-reinforced ionomer, the fluoride release long-term really in most of those cements is not negligible. As we move down the list, the next group of cements that have become popular are self-adhesive resin cements. If we look at these groups of cements, all of these cements I've talked to addressed so far, I would consider them conventional cements, mix and place. Self-adhesive means there's no treating of the two structure prior to. The cement is a acid-base mixture, usually an auto mix tip now, that's mixed and squirted into the prep, or onto the prep or into the restoration, and then the crown or restoration is placed. Now, these definitely bond to dentin. There's some question as to the efficacy of bonding to enamel with any self-etching system, just like self-etching bonding resins for composite. The uncut enamel is still not affected as well as far as a bonding surface as it is when it's etched with 37% phosphoric acid. So is there some bonding to enamel? Well, depending upon the product, depending upon the material, depending upon the pH of the material, there may or may not. But is still some adhesive property to dentin, and it is these materials are non-soluble. A new class of cements actually that have been on the market for a little over a year, glass ionomer in combination with calcium aluminate. This is almost a new group that is just starting to evolve in the cement category, a group that I refer to as smart cements. This particular category of cement has the ability to form microcrystals that integrate and become part of the apatite. There are newer versions of self-etching cements that are quote-unquote smart cements that have different types of properties that are improved from these first layer or first level of self-adhesive resin cements. So the cement category is evolving. This new category, we are getting bonding of dentin and enamel. And resins with adhesive systems have always been the top as far as bond strength to enamel and dentin. That means total etch. We get bonding of enamel to dentin, and you look at this whole line of cements increasing bond strength as we go down. Now, let's address this bond strength thing and talk about selections of cements for which system, for which product. Because clinicians are confused. Many are not even aware of all the parameters that affect cement selection. For me, primary factors in cement selection: preparation design. How much mechanical retention is there? Is there an adequate axial height and minimal taper of preparation? See, there's no cement that's going to be able to allow us to bond to a flat stump. So mechanical retention and resistance form of the preparation are key factors. If you have a prep that's at least 3 millimeters tall and has a 5 to 10 degree taper, you can cement pretty much with anything. and get good retention. It's when those qualities lessen that we have to start thinking about, do we have different products that can increase the ability to adhere to a less retentive prep or a more tapered prep. The other primary factor, which I think is critical to remember, is the ability to isolate the operating field from moisture. Because most of the conventional cements, particularly early on, zinc phosphate, Duralon, glass ionomers, even resin reinforced ionomers, these products are not, there's not as much of a problem if there's some moisture contamination. In fact, you'll get sensitivity with glass ionomers cementation if you over dry the preps prior to cementation. They actually like a little bit of moisture. So where's the margin position of your restoration? If it's super gingival and isolation is perfect and you've got a short prep, you go with the most bond strength, and that's acid etch and resin cement. If you've got a margin that's down in the sulcus in its posterior location, molar, hard to isolate, you want to go with the easiest, most moisture tolerant type of material. And choice there could be either a self-etching resin cement if you can control the moisture long enough. If you can't control it at all, I'd go with a resin reinforced glass ionomer. So the ability to isolate, the preparation design, these are factors that help decide which cement to use. And then lastly, the ceramic system. You know, if it's pressed ceramics or feldspathic, you really need total etch. Some of these all ceramic systems can be cemented with anything. If you look at zirconium, now zirconium is starting to be used a lot more than gold. We're looking at cements now that can adhere better to zirconium. So we have a lot of choices today. The prep design, as I said, you need adequate resistance and retention form. Bond strength is not as critical to clinical success when you have a good prep. And you could use just about anything. Glass ionomers, resin reinforced glass ionomers, self-etching resin cements, glass ionomers / calcium aluminates. Those types of materials can be used. However, if there's a variable of ceramic selection, then you have to consider adhesive. Or if the preparation is a little bit short, or if the taper is a little bit too much, or if you're in the anterior and you really need a high lip line with advanced aesthetics or a need for detailed aesthetics, you may need a total etch type of cement because the ceramic dictates that. So these are some of the things we think about with cement. As I said, zinc phosphate, the bond strength 0 megapascals, used successfully for many years. So here's some parameters. I would consider minimal preparation axial height for conventional cementation in any of those cement categories or product types that we mentioned. 3 millimeters is it. You need to have at least 3 millimeters of 5 to 10 axial taper. And then you can cement with anything. If the preparation height is less than 3 millimeters, and this is just for comparative reasoning or just to look at things in a comparative way, total etch technique and resin cement, so acid etch, bonding resin, and resin cement, only make up for a 0.5 millimeter of lost prep height and 5 extra degrees of taper. In other words, if you compared these two standards, they'd be pretty much the same. Total etch and resin cement will only give you the amount of additional retention that's equal to about a 0.5 millimeter in axial height or another 5 degrees of taper. So you see, again, it goes back to the thing that resistance and retention form are the most critical things for clinical success. So let's look at some cases. And we've got about 30 minutes left to our webinar. And this first case, cementation using a resin-modified glass ionomer cement. I'm going to introduce you, probably you're familiar with the Fuji products. Fuji Sem 2 is an improvement from Fuji Sem over the offering in the resin-modified ionomer cement category from GC. One of the bigger improvements that, again, from my own perspective, has been also the delivery. having a delivery system that has a nice convenient syringe that a lot of times I will go with the cement right to the tooth or fill the prep. I have the option, but this delivery system is very convenient. This particular bridge, 5-unit bridge, porcelain fused to metal. I chose resin ionomer as the cement because of intraclavicular margins. It wasn't impossible to isolate, but you've got a tongue right here, and you've got the parotid gland up here, and you can put I usually put a triangle up there, but a lot of times in the far posterior areas, the patients don't open wide enough. The tongue is always continually touching that last tooth and contaminating it with saliva. So this, I think, was a difficult isolation type situation. Plus, I've got a metal post core in one of the abutment teeth. So we're going with a resin modified ionomer with Fuji Sem2 here, and here's the occlusal view of this particular case. People have asked me before when I show this case, why is this splinted to the canine? Well, the reason it's splinted to the canine is because the tooth that's root filled has a very short root, and this premolar, the first premolar, also, the crown root ratio is not that great. And the fact that the span is so long, my choice here was to splint to the canine for additional strength. So when we look at Fuji Sem2 as a product and compare it to the previous generations of Fuji Sem, there's a couple of things that make Fuji Sem2 different. First of all, the flex. High elastic cross-linking monomers, and you can read the slide here. There's been improvement in the elastic monomers that cross-link this material to increase the flexural strength and allow it to act more like a shock absorber, resisting occlusal load, because we know these materials, they don't do too well under occlusal load. And when I say this, I mean the glass ionomers as a category, and the flexural strength, it can be an issue. You saw this particular patient with the wearing on the opposing dentition or opposing crown and bridge. He can get those muscles going pretty good. So this material acts like a shock absorber. The other thing is the filler surface treatment, creating a strong bond between the glass particles and the resin matrix. What makes this graph interesting to me is the fact that GC actually compared properties of their old cement, Fuji Sem, to the new cement to see the increase in shear bond strengths that were achieved both to enamel and dentin with the newly modified Fuji Sem2. So higher bond strengths to ground enamel and superficial dentin than the original product. So my clinical steps of treatment: first, after removal of the temporary, I clean the preparations. I usually use a dentin desensitizer like Aquaseal, Gluma. You could use I use it for the antimicrobial effect, obviously, and we've got exposed dentin. But some people like to use Concepsis or Prep Clean. You want to just make sure that the surface of the teeth, that they're not contaminated in any way. Recently, I've gone to using Prep Start, a Danville micro etcher with water to clean the preparations and make sure that the cement is cleaned off the surface to get good uniform retention to the of the cement to the tooth. So make sure the preps are clean. And the Fuji Sem2 is auto-mixed and injected directly into the restoration and placed with finger pressure. And I hold this in place, or my dental assistant, I have the blue gloves, my assistant has the pink gloves. We hold this in place for a good 90 seconds. I don't have the patient immediately just bite down, because if they bite to one side or the bite isn't even, they could dislodge or displace the restoration prior to its initial set. I want to make sure it's fully seated, and I do that with finger pressure for the first 90 seconds. Then I'll have the patient bite down and examine both sides to make sure that there's equal intensity, that they're not closing only on one side. Then have them open, and I put cotton rolls on both sides to balance, and I have them squeeze into the cotton for the next several minutes until the final set is achieved. At that point, you can literally take an Explorer, and a Fujisem 2 will just clean right off the margins, as simple as that. Just peels right off the margins in ceramic very easily. I can get in between in the posterior area here with floss threaders and the piezo scaler again to get any little last vestiges of cement removed. And here is our finished cementation on the lower right. Move on to the next category, next case, using self-etching resin cements. Here's two zirconium restorations, central incisors, lava. The preparations have been cleaned. Now, traditionally when I'm using zirconium, I will always use a IvoClean, which cleans up, decontaminates the surface. If you're doing try-ins, is saliva, phosphates in the saliva can contaminate the inside of the zirconium and decrease the bond strength of any cement. So products like IvoClean will clean up the inside of the restoration prior to cementation. And in this particular case, we're using self-etching resin cement. This is GSEM. Now GSEM comes in a capsule form, which is triturated, or it also comes in an auto mix form as well. Now in placing a restoration with self-etching resin cement, again, I hold that restoration in place for a good 90 seconds. I think most dentists want to clean this stuff up too quickly. Now I may hold this in place very tightly and take a brush and start brushing. So when I take a brush, I mean a soft sable brush, and start removing the majority of the excess, but brushing toward the tissue, not toward the incisal. So hold in place for 90 seconds. Don't be too quick to clean up. At that point, as I said, you can hold the restoration and use the sable brush to clean off the excess. At a gel set of about 2 minutes to 2 minutes and 30, you can clean up with an Explorer or fine scaler, and then check with floss, and your restorations are completed. Now I mentioned some of the newer self-etching resin cements that are out on the market. One of them is an improvement to GSEM, which is called GSEM Link Ace. And Link Ace, you'll see here, has some features and benefits, and the one that really draws out in my mind is the one that I've highlighted in red here, the optimal self-cure mode. Most of the resin cements, self-etching resin cements with auto mix tips, are dual cure, or all of them are dual cure. And we're told you can either cure with light or cure on their own. Well, next time, just for the heck of it, whatever cement you're using, go into your operatory and take some of that cement in the auto mix tip and squirt it out on your bench and put a timer on and see how long it takes for it to cement, or for it to set on its own. Self-cure. You may be shocked. Some of them may never set. The self-cure mode is not as good on some as it is on others, and obviously we need to rely on a good self-cure mode when we're cementing PFMs, when we're cementing zirconium, anything where light doesn't get through. One of the other properties, as I said, we're looking towards cements that have the better capabilities of bonding to zirconia, because zirconia is not etchable. Link Ace has good color stability, very low water absorption, HEMA-free, and easy removal. Just like I said, you can either tack cure it in 2 seconds, 1 to 2 seconds, and remove it, or wait for the gel set. This is an interesting slide to show the self-cure mode, because if you've got the ability to get the light through, no problem, everything will set. But if you look at porcelain fused to metal, no light goes through. Even some of these zirconias, you think that no light is getting through. A little bit is getting through, but not that much. How about Emax? You think light would go through Emax quite a bit, but not that much, particularly when you've got layering on top of it. So you need to have a good, reliable self-cure mode with a resin cement. Bond strengths here, this slide's a little bit hard to read, but just comparative, some initial bond strengths to Denton and self-cure mode are extremely good with this product. Again, most bonds mature over time, and bond strengths improve over time. But what's one of the questions your patient asks you? How soon can I eat? And many different approaches to zirconia today. One nice thing to remember about a product such as Linkase is that you don't need extra products and materials to enhance the bond. It's simply a one-step. You squirt the material into the restoration. I still clean the inside of the restorations after trying, but then basically squirt the cement in and place the restoration. Same thing with Emax, whether it's Emax CAD or whether it's pressed. Now, looking at this patient, we're not going to have time to go over a lot of the details, but this was a Class 2 Division 2 patient. Actually, Class 2 Division 1, deep bite Class 2, who came in for a restoration. And these typically are cases that need to have vertical dimension recaptured. Vertical dimension of occlusion is a muscle position, not a tooth position. When a patient phonetically says 55, 66, you judge the amount of freeway space between the upper and lower cusps. At rest, and again, my mentor Harold Chevelle always said you can restore to the closest speaking space, which is freeway from Earl Pound, 1 to 2 millimeters. So a patient like this with a deep bite, when they say 66, if you go back here and look and they've got 4 to 5 millimeters of freeway space between these upper buccal cusps and lower buccal cusps, you can actually build teeth under here and not open the vertical dimension. Here you can see a very restricted arch, probably not prepped particularly well on the lingual surface because these have been worn not by the patient's opposing teeth, but they've been worn with a burr to adjust, because here's what the patient's opposing teeth look like. They're worn down considerably. So one thing Chevelle always said, empiricism restrained by reason. We have a wax up done. We go back to this slide. I take full mouth study models, FaceBow, mount this on a semi-adjustable articulator, send it to the lab, and ask the laboratory to open up the articulator to be able to wax these teeth back to the way they were before the excessive wear. And then we'll test that out in the patient's mouth. And that's the best articulator in the world, isn't it? So on this case now, this patient has been in provisionals. We're going to cement the case. On these types of cases, notice the second molars, not prepared. I always leave the second molars as a reference point to the original vertical dimension should I ever need to go back. I'll come back and prep the second molars after the reconstruction is finished. So, thinking about cement selection here, the original crowns were PFMs and they were subgingival. We have pretty decent isolation, or lack of, let's say not isolation, but lack of contamination because of healthy tissue. So we're going to use resin, self-etching resin cement, Linkase. And I usually cement 2 by 2. The first thing I will do is I'll try in all the restorations individually to check marginal fit. Then I'll try them all in collectively to check contacts, but don't get complacent if they all fit passively together. There may be micro movement. I used to work with someone who would say, oh, I just cement them all at once because then I don't worry about the contacts not fitting. Well, if you got to worry about the contacts not fitting, and that's the reason you cement them all at once, there's going to be a fit problem somewhere. I call this cementation technique the Noah technique. Why Noah? Because Noah put the animals in the ark 2 by 2. I place the centrals, I remove excess cement with a brush, make sure there's no cement on the lateral preps, and then I place the laterals on the preps to hold positional space while initial set occurs on the centrals. Hold for at least 90 seconds, or light cure for 1 to 2 seconds and clean up, and then go on to the laterals. Now, on the laterals, I notice a little bit of chance of bleeding and contamination. So I'm going to use retraction paste. Could be Expacil, could be Traxident, could be Dry-Z from Parkel, or several products on the market that don't, in my opinion, necessarily take the place of retraction cord, but great hemostatic agents. If I see something like this at cementation, or I get a little bit of bleeding from etching prior to total etch cementation, I use one of these products to stop the bleeding. I don't pack cord in during cementation. So you can see here, no bleeding, no issue. The cement goes in the laterals, the canines hold positional space. And as I said before, and this is just showing some of the intermediate steps before cementing the cuspid here, I'm cleaning with an antimicrobial, removing the excess that is come out of the side of the canine crown here so that it doesn't get on the premolar prep, so that I can set the crown on the premolar to hold positional space for the cuspid while it seats and while it gets initial set. Here the cuspids are in, the premolars are holding space. Now as you go back to the front, here's the piezoscalar going in between and just loosening little pieces of resin cement or cement tags that may be in between, using my time while I'm waiting for initial preliminary set of these last two. I always take pre-cementation, post-cementation radiographs. This is DEXIS with digital x-rays to make sure that the cementation is progressing properly. And I tell you, even when everything fit passively, this last molar does not go in without a contact adjustment. Checking with floss, marking the contact on the study model, and then taking a porcelain polishing wheel, erasing the contact, or erasing, not the contact, but erasing the blue mark, and then going back and trying it in. And you may do that 2 or 3 times, and then finally that restoration is seated. So here we have the entire case, upper case, seated with just adjustment of the distals of the second molar. Now, the other thing that I didn't tell you that I'll mention now is when I did my passive try-in of all these units once prior to doing any cementation whatsoever, I tried in each unit individually and checked with an Explorer, and then I tried them all in to check passivity of fit. I also had the patient close down gently. These are temporaries on the lower, and you can see the occlusion on the temporaries is so close that I know that I can cement the entire upper arch with minimal to no adjustment. The reason the occlusion is this close is because when I take records for the laboratory, the provisionals will hold the vertical dimension on one side, and we'll take a prep-to-prep occlusal record on the opposite, and then do the same thing with provisionals on that next side, and vice versa, as you can imagine. But I also put the provisionals back on the upper arch and take a second record of provisional to prep. This is usually done with a vinyl polysiloxane for stability, and then the laboratory then can mount the prep to prep and prep to provisional models in the lab and and switch them out on the articulator, so that the occlusal plane, when the technician is developing the occlusal plane in ceramic here, he's got the opposing provisional occlusal plane to get the proper curve of speed, curve of Wilson, and all that type of information. We get very close. Now, trying in the lower. This is not necessarily a great case to discuss this, but this is what I do. I want 3 potential points of contact, the 2 centrals and the most posterior contact on a new restoration on each side. Now, we see the 4 incisors here because these are splinted. Remember, those preps were not very retentive because of the excessive facial wear. So this is a zirconium splint, and this molar was a very short prep. tooth number 19, first molar, on the lower left. So I splinted that to the premolar. So that's why there's 2 crowns here, 1 here and 4 in the front. But I want this patient to close down and touch these simultaneously. If the patient closes and there's no contact in the front and there's touching in the back, then I may take out this one on this side and see if the front touches. If it does, that tells me that this is the premature contact. If it doesn't, then both of these sides are in contact prematurely. And that's what's going on here. As you see, here's the lower preps. I cement the anterior bridge first. And then you see most posterior on one side, most posterior on the other. I've got contacts on both posterior upper molars, but no contact on the anteriors. So I adjust and polish those contact points until we get good, as Chevelle called, occlusal lock. I can see that good A, B, and C contact form here in the most posterior tooth closest to the joint. And then I'll move forward to the next one and try that one in, and move forward to the next one after that and try that one in, adjusting as I go along. Much easier than putting all the units in, marking them all with this blue paper, and then trying to figure out where the first contact is. This here, I've got contacts in the back, I've got contacts in the front. Now we move forward. Add 1 unit there, add 1 unit there, and try it again. As long as everything's still touching and the anteriors are touching, we progress forward. If not, we identify the tooth that needs to be adjusted, and we adjust it prior to cementation. Much easier to adjust and polish ceramic outside of the mouth. Finally, we get to the last unit on each side, which is the canine. The canine is tight. It does not go down. I'll take a piece of articulating paper, place it next to the distal of the lateral, seat the restoration, get a mark where the contact is tight, place the restoration back on the die so that it doesn't go spinning off and hit the wall, and gently remove that blue mark and try it again, and finally it fits. Now, I don't do full mouth rehabilitation in my office every day. Most of my crown and bridge is just like in your offices, single teeth, 3-unit bridges, maybe a quadrant of crowns. This works for any situation. Let's say these are all natural teeth. Let's say these are all natural teeth, and you're replacing second molar or first molar, second premolar, first premolar, canine on this one side. You have 1 point of contact in the anterior on natural teeth. You have 1 point of contact in the posterior on the opposite side, natural teeth. You place the farthest restoration from the midline closest to the joint, that single restoration. You place that, check with articulation. If you're not touching here or here, obviously that's a height point of contact. If you put this, if you are touching in the front and on the other side, then you put in the second one and you check and adjust. This system works regardless of how many units you use or you have to deliver. Here's the upper arch, here's the lower arch. Now going through excursions, here's right lateral. You can see canine guidance and anterior coupling. Here's left lateral, canine guidance, anterior coupling, and protrusive, shared guidance on the 4 incisors. Now, you saw the wear on this patient initially, and people always ask me when I discuss this case and I show this case, well, did you give the patient a night guard? You saw that wear. Did you give him a occlusal guard? I give all these patients occlusal guards. They're insurance for me, not for the patient. This patient was an unusual patient. This patient said, you know, Dr. Lowe, I'm never going to wear that thing. And I said, well, you know, you saw the wear, you saw how you destroyed your own teeth. There's nothing that I can do that's going to be permanent, that's going to last forever. If you don't wear this guard, you're going to wear down your restorations, and we're going to be back here again redoing this. And he said, I understand that. I'm just going to tell you, I'm not going to wear that thing. And this patient has been rehabilitated now for over 8 years, comes in every 6 months, no issues whatsoever. And that's not going to be every case. But when you have the ability to restore to a canine guided occlusion, and Chevelle always taught us, Every movement from centric occlusion relation position should result in immediate disclusion of posterior teeth by virtue of canine guidance and anterior disclusion. If you can have that in the system, precision is more important than position. Here's our patient finished at over a year. You see, he didn't want to come back right away, and these teeth didn't super erupt. He'd had enough of us for a while. These teeth did not super erupt into place. A year later, he comes back and we restored the second molars. Here you can see front and back at about 5 years, and his full smile. Now we go to the last case I want to show you with a combination of cementation techniques. This is Robin. Robin has just been recently restored, and she was referred from another restorative dentist here in town. I always am a little bit nervous when I've got implants already placed on the patient. I didn't know whether a surgical guide was used, where the positions were relative to the opposing crest of bone and occlusal tables and all those other neat things. But with Robin, again, we went and we had a wax up done to ideal tooth position. Here you can see, if we open up what she's looking at back there, quite a bit of bone loss and tooth loss over the period of time. You know, super eruption of this terminal molar, but still relatively sound. But you can just visualize the plane of occlusion. That's going to need to be corrected. You're going to need to have abutments that support understructures, that support porcelain, because the distance from bone to bone is rather large. Here's her upper arch occlusal view, lower arch occlusal view. Now, if I had my druthers, I would have liked this implant just a little bit to the lingual, maybe a little bit to the distal, and this is a little close to the canine, but not bad, not bad. We can certainly work with this within the confines. And here's preparation day. Prepared the upper arch. We're going with, again, full arch wax up. I will prepare half of the arch and we're not changing vertical dimension on her, so her original vertical, these teeth are unprepared. I prep these, make the temporary on that side, do the same thing. These temporaries are splinted so that you can do both sides individually. Here's her upper impression with the implant impression copings in place and the provisional restoration cemented with Fuji Temp LT on the top. This was our first appointment. Second appointment, lower preparation, implant impressions. I use a 2-chord technique, 00 underneath, number 1 chord on top. I pull the number 1, leave the 00 behind, and a nice, perfect cuff impression all the way around. Now, taking bites are important. Keeping the vertical dimension constant, and I do this at every try-in. This is the second appointment. The upper's been prepped, the lower's provisionalized. I've split the lower provisional, so this provisional is holding the vertical dimension. I use putty on this side because the inner arch distance is so huge, and make a putty registration there. And then I'll take the provisional out here, make another putty registration over here, and then because I didn't want to take the entire full upper provisional off, again, remember I mentioned it was sectioned. I just removed the anterior so that I could get a prep to prep in the front with a moose bite. That's futar. So here's where we started. Here's provisionals. Decided not to engage these healing abutments. My first appointment was going to be an anterior try-in to verify a vertical dimension of occlusion, verify and look at the aesthetics, look at the tissue contour, and to try in the implant abutments. So here you can follow along on the model and in the patient. Here we're trying in the anterior teeth. These are Emacs, upper and lower. You can see our arch positions in the posterior are constant. I retake the bite with the units in place on both sides and in the front. so that we can double check on the articulator what we have in the laboratory is accurate. And I tell you, I even got a question from my laboratory technician on here. Christina Jasinski from Houston did a beautiful job on this case for me. But she calls me and she says, "Are you sure the bite is right? There's too much room. There's too much distance in the back." That's another reason why I take pictures. I send her all these pictures. I retake the bites. I said, "Christina, yes, the bite is correct. The bite is correct. We have to make sure and support the porcelain. You don't want to have porcelain hanging off more than 2.5 to 3 millimeters." So we verify what we've got with the bites, and the lab is correct. Here you can see in the bite, this is the class 2 relationship that the patient has. Here's the Emax restorations on the bottom. We want to close triangles a little bit if we can. Remember, she had a lot of recession. Copings now we're going to try in on the units. These are CapTech. CapTech is marvelous for implants because there's no shrinkage. There's absolutely a passive fit with CapTech. So I use CapTech, and I splint these and don't make them single units because if they're splinted, they're retrievable. CapTech also is very biologically acceptable, and these margins are down near tissue in some of these cases, as you can see, because the copings are long, the furca are exposed. So these are CapTech copings. I do a coping try-in. Again, I want to gauge the amount of space because here's where the porcelain's going to be. Split half and half, it's perfect. Split half and half, it's perfect. Anterior bite is good. So now we'll go on to a second try-in. But again, I'm going to take another bite with the copings in place just to verify what we have on the articulator is what we have in the patient. I also do a pickup impression so that the technician can fill in around tissue contours as much as possible. I put a drop of temporary cement, a Fujitemp, just a drop in the incisal edges so that these units don't move. And then I place the CapTech copings on the implant abutments. And then I pick these up. I inject light body all around, pick it up in a full arch impression. And the same thing on the lower. Now we've got excellent tissue models with the copings in place. Here are the restorations completed on the laboratory models. Side views. These are Emax and then Emax pressed to CapTech. And here are the units on the bottom. We've got an individual unit here, a 2-unit implant splint on CapTech, an individual CapTech unit here. I'm sorry, this is canine. This is all ceramic Emax. The posterior units, the second premolars here, are CapTech and CapTech units on the implants. So we put in the healing abutments, torque them to 25 Newton centimeters, all in place. Everything looks good. There's the tissue health, superb, between visits from good provisionals, cemented with Fujitemp, no problems with recurrent decay or issues around the margins. This patient was, undergoing treatment for several months. Now with our CapTech, I'll use a Danville micro etcher just to make the internal surface a little bit more retentive, and cement these with Fujicem 2 resin modified glass ionomer cement. And here's our posteriors. Look at the occlusal lock from Chevelle. Not bad for a class 2. Split the difference. Nice positioning of the occlusal plane. Here's posterior views. And then the anterior units in place. We close those embrasures in the lower as much as we could, but they're nice and cleansable. We are down our root surface quite a bit. You can't really close all those black triangles in the lower. Not really that much of an aesthetic issue at all. So now the steps in cementation. These Emax units from Christina's lab come back unetched, so I'm etching them with hydrofluoric acid, rinsing, and then silinating. Here are the preparations, and I've tried these in. Everything looks good. Clean them. I tried them in prior to etching and silinating. Now we're going with Link Ace. And there's the first two. I'll remove the excess. There's the second two. Remove up after 2 minutes. We get a little bit of a gel set. Remove as much as we can with the brush. Remember, you don't touch these for 90 seconds. And after 2 minutes, very easy to remove gel set with a scaler or a brush. And we've got these upper 6 units in place, and now we're going to do the same thing on the lower. As my cardinal rules, I usually do 2, 2, and 2. These fit so nicely, and we did them all with link case at one time at 6 at once. Cleaned up the material in between with the brush. Then I spot cure and check the contacts with floss. Final cure, and we're finished. So here's where we started with our patient. Here's where we finish. Combination case, resin modified ionomer in the posterior on implants and with CapTech using Fuji-Sem 2, and then on the anterior units with Emax using G-Sem link case. Here's where we started at the beginning, and here's our 2-week follow-up with our patient. Here's where we started again, panoramic view, and here's our 1-month follow-up. She's doing fantastically. Here's our before, and here's our after.